Good afternoon, everyone. My name is Dr. Mutumwa from the UTH Hub, and with me here at the Hub is Dr. Angel Mubanga, the manager for the National Tuberculosis and Leprosy Program. And today we are going to discuss the priority areas for the TB program in the year 2024. Just to repeat the housekeeping rules, please ensure that your mic is muted at all times, and also raise your hand when you have a contribution to make, and utilize the chat as much as possible. Apologies for starting the meeting a bit late. We had some technical issues to sort out within the Hub, but we do promise you that that will not take away from today's discussion. So, also, just to mention our panel of experts. So we have a number of experts from within the TB space that are going to be supporting this discussion today. And these are Dr. Chimzizi from the NTLP, Dr. Ziko from CIDAS from the USA TB Loan Project. We have Dr. Muyangana from CIDAS. We have Winnie Mwanza from the Ministry of Health. We have Dr. Mputu from Ministry of Health, and we have Dr. from USA. So this will be the support staff for this afternoon. Without taking up much of the time, I will hand over to our presenter for this afternoon, Dr. Mubanga. Doc, welcome, and over to you. Thank you.
Thank you so much, Dr. Mutumwa, and indeed it's a pleasure to join the network in discussing issues around TB. So colleagues, as I've been introduced, maybe we can switch seats, Dr. Muyangana, so that I'm close to the... Okay. I also have that.
Area TB. Priority areas for the TB program in Zambia.
Just an apology from colleagues, if we can just mute our mic so that at least we are together as we are doing the presentation. So today, I'll look at 4 main objectives. We'll just preempt the discussion at the end of the presentation. So the first thing that we want to look at is just the progress that we've made towards the NTB global elimination TB. That is the 2030 goal, and then beating targets, both the low dramatic 24. And also the new UN high-level meeting targets that we've been given as a country. And I'll also preempt a discussion on the shorter treatment regimen that includes for children and also DRTB and also TPT. Then finally, I'll give the key highlights when it comes to focus areas for the program as of the year 2024. So just a brief introduction. The picture you are seeing in front is just a snapshot from the TB profile for Zambia. It's an extract of the WHO report for 2022. As you may be aware, some of you might be joining the program for the first time. We report, WHO report covers a year ago. So the report that we are looking at as the latest report is for the year 2022. So when we look at the profile for Zambia, you find that our burden still was estimated to be 59,000. And of that, we were only able to identify about 54,848, which translated to about an incidence of 295 per 100,000 population. And when you look at the MDR, we still have a high burden The estimated incidence for MDR still remains at 1,900 for the country, but what we were able to identify was somewhere 362. And that in itself is a very small proportion of the cases that we are finding. When we look at the mortality, we continue seeing a decline in the mortality over the years. And of this year, the mortality has reduced from the previous 2021 report of 40 per 100,000 to about 27. But as I always mention to say, any mortality is always significant because that might be actually the breadwinner for the day. Now, allow me to take you a bit to the right of my presentation where we have this green, yellow, and some pink color. So when we look at the green color, it shows us the reduction in the incidence. The black color line that you are seeing going up, almost touching the green line, it seems to be obstructed. I hope people can see what I'm trying to explain there, is the case notification for the country that we have. And then the red color just shows the incidence in the HIV positive population. But of note is what I want to bring out to you is we have seen year by year, we are always finding new cases. And this almost is pushing us to a point where our estimated burden will be able to find it. So does it mean TB has ended in Zambia? So again, it calls for us to have a retrospective analysis and also look at the current estimates. What are they using? They are basing these estimates based on the prevalence for TB that was done in 2014. So as a country, again, it is pointing to us to say, can we have something new that can inform us what is the true burden for the country at this point in time? I thought I could give you that background. More of that information, feel free to check the WHO page. You'll be able to find it. And also our annual TB report for the program. And move forward. Over to you, Dr. Muyangana. I think I wanted to warm you a bit up so that now we get into the nitty-gritties of the presentation.
Okay, so we are now going to assess how much knowledge we have towards TB as participants of this eco session. So the first poll question is towards the progress that we have made towards meeting our 2025 milestone to end TB. And the question is, according to the World Health Organization End TB strategy, the following percentage of TB patients and their families facing catastrophic costs should be. I will read that again. According to the World Health Organization End TB strategy, the percentage of TB patients and their families facing catastrophic costs should be. So please pour in from those options. So A is 80%, B 75%, C 0%, and D 50%. What percentage of people that have TB and their families should face catastrophic costs due to TB? What is your opinion? I can see only about 125 people have poured in. Please answer that question. Keep those polls coming in, okay? We'll give it a few more seconds. We'll be ending the poll shortly, okay? We can end the poll now. So Dr. Mubanga, the participants think that, or rather the majority of the participants, 67% think that there's no family should face catastrophic costs due to TB, while we have 11% thinking 75% of TB patients and their families should face catastrophic costs, and we have 13% of the participants thinking 80% of these should experience that, while we have 8% thinking the answer is D at 50%. I think you can shed more light on that.
Thank you so much, Dr. Mutumwa. And indeed, it's good to know that at least 67% of the people are thinking no family should suffer any form of catastrophic cost when it comes to TB. So I'll take you now into the next slide. So colleagues, when you look at the NTB strategy, it has got the 3 major key indicators which are tracked. And this NTB strategy, as we may be aware, was formulated in 2015 with a focus to end the TB by 2030. And it has been embedded in our Sustainable Development Goal number 3. So it has got those 3. The first one is the incidence. The second one is the mortality. And the last one is the catastrophic cost. So what does it state? So when we look at the milestone that we are supposed to say, now we've ended TB by 2030, which where we are heading, it's about 6 years now from now, is that the incidence for TB with the baseline of 2015, we are supposed to at least reduce it by 80%. Then for the mortality, any cause of death that is related to TB should at least reduce by 90%. And at every point from the beginning, when it comes to catastrophic cost, and for those of us who might be joining and might be wondering, what is this catastrophic cost? It's a cost that someone incurs as they have developed the TB. It can be related to the family that pushes them into poverty. And when you come back to the definition of who are the risk groups for TB, it's actually the poor. Now, if they are already poor, it pushes them into poverty. I think for me, I translate that it pushes them into death. So no family should suffer any catastrophic cost. Now, based on the 2015, it has got milestone 2020, 2025, 2030. So by 2025, again, since we've already passed 2020, we are looking at reducing the incidence by 50%. And where we as a country, we have only done a 25% reduction. When it comes to mortality, we are supposed to reduce it by 75% in 2025. And where we as a country, we have already passed this milestone. We are already at 77% as of the year 2022. So this is an indicator where we feel confident that we might pass it and reach it in good time. For catastrophic costs, we are looking at 0. But as of 2020, 2021, we've reported to say we have at least 58% of our patients actually being pushed into poverty. So what does that mean? Before we beat ourselves, I can give a global reduction. So that was for the country. Now, when we look at the global reduction, how are we doing? Incidence reduction globally, we've only reduced it by 8.7, meaning as a country, we are above that, which is a part on our shoulders, but more needs to be done in that area. We look at the mortalities again, only 19% has been achieved globally. And that again, we've passed it. For catastrophic cost again, the global picture is that we have about 49% of the people globally who are facing these catastrophic costs. And as a country at 58. So here again, even more efforts is being needed for us to move it to 0. Now, just a few updates now on what has contributed to that reduction as a country that we have summarized into the incidence, the mortality, and also the catastrophic cost. So there are a number of things. So the first thing I think is the way we have performed in terms of identifying patients and linking them into care. So when we look at the trend, it has always taken an upward trend. And as of 2023, the data that we have, which we are doing verification on, is we've notified above 53,000. We are about 53,800 and something cases that were reported. And we attributed a slight reduction to a few measures that we had found in the misuse of some of the diagnostic tools that we are using at our facilities like urine lab. So we hope this year we can add quality to this and have more cases whilst maintaining the good performance. We look at pediatric notifications over the years. I think we are hovering around 7–8%. In 2022, we notified about 11% of all the cases that we had notified were actually pediatric. This is a key vulnerable population that we are always tracking as a program. And as of 2023, we've sustained this 11% as a figure as well, as a proportion as well. When we look at, we are talking about having real cases. Of course, clinical diagnosis still remains critical in the fight against TB, but we would want to see more bacteriologically confirmed cases. And according to the WHO, at least 70% of our cases should be bacteriologically confirmed. So how have we hovered around that? We will note that in 2018, we recorded a high bacteriological confirmation, that of 6%. And by then we had just expanded the expert machines to various provinces. But we've continued increasing the expert machines and other molecular diagnostic tools to contribute to this performance. However, a paradox has been happening. We had noted a decline in the bacteriologically confirmed to about even 49% in 2022, the year we are reporting on. But as of 2023, I can report again, the data that we have is that we have scored about 56% going back to the 2018. And our projection is by this year, 2024, we should move to about 65%. And looking at the efforts that you colleagues from the districts, the provinces are putting in, I think it's something that is attainable. When we look at MDR-TB, we will see that, again, we started on a good note when we started with notification. Our projection came from as low as 196, which is 33%, to about, we moved to 627, which was the highest number we had recorded in the same 2018 when we had a high bacteriological confirmation as a program. So this was good, but over the years, again, we have seen more of a correlation between the increase in the clinically diagnosed as also related to the MDR cases. But of note, again, a good performance has been noted in the treatment success for MDR, where we have continued going up. And as of 2022, we had 79% as our treatment success for our MDR patients. And our target, I think we'll look at the target for 2023, 2024. You'll see that it's heading in that direction. You can move forward. Again, when we look at treatment success, this one is now for DSTB. In fact, this is treatment coverage compared to what we are supposed to find. Again, as I mentioned, we keep on finding more and more cases that we are linking into care, almost taking us to 100%. And it can be explained with a similar picture that I had earlier presented in my introduction, where we are seeing this increase in notification almost meeting the burden that we've been given as a country. Now, what will happen there if we meet there? Will it mean that now we've ended the TB? It's a question that is we need to reflect on. And as I mentioned, I think a scientific approach to what next steps need to be taken needs to be done in form of even a prevalence survey that can inform us the true burden of the cases in the country. Okay, when we look at partly, I've mentioned about the treatment success, and these I think should come under the targets. I think we'll talk about them as part of the targets. I don't know how the slide had managed to move up here. Over to you, Dr. Muyangana, for the next part of the discussion.
Okay, so we have our next poll question, and this poll question is towards the targets. And the poll question is, in the 2023 to 2027 UNGA commitment has targeted universal access to WHO recommended diagnostic tests for all. So the 2023 to 2027 UN General Assembly commitment has targeted universal access to WHO recommended diagnostic tests for all. So is it A, 90%? Is it B, 80%? Is it C, 100%? Is it D, 95%? So Kote, you can just help us to launch the poll. So as we are waiting for the poll question, we can digest the question. The 2023 to 2027 UNGA commitment has targeted what percentage universal access to WHO recommended diagnostic tests for all? Is it A, 90%? Is it B, 80%? Is it C, 100%? Is it D, 95%? Okay, it seems we're not able to load that poll. Dr. Mubanga, I think we'll just move on to the next slide as we digest the information about this poll question. Thank you.
Thank you, Dr. Muyangana. So when we look at the 2023-2027 UNGA commitments, this follows the UN high-level meeting that was held last year in September. That is in New York, where our heads of states participated and recommitted to NTB by having an impetus to actually have this done in their local settings. So they had come up with critical areas that should speak to those 3 key areas that we mentioned about reduction in the incidence, mortality, and catastrophic cost. And one of the objectives that they mentioned was for universal access to WHO recommended TB treatment for all, meaning the people that we suspect to have TB that burden, how much of them should actually access, should be identified and be linked into care. They committed to say about 90% of the people living with TB should be identified and be linked into care. And this speaks to the treatment coverage that we are talking about. So when it comes to now the molecular diagnostic tools or test access by the community or by the people, all patients that we suspect to have TB should have access to a molecular diagnostic TB test, which is 100%. So 100% of all our people that we identify or we say they are presumptives for TB, we are supposed to have them actually exposed to one of these molecular diagnostic tests. Then when it comes to TPT again, they have committed to say 90% of all eligible people who are eligible for TPT should actually be initiated on TPT. When it comes to catastrophic costs, they have just twisted the language. Instead of saying 0 catastrophic costs, they say 100% of all eligible people with TB who are potentials of getting into catastrophic costs should be covered with social protection. So the heads of state have committed to say we need this to be happening, and this cannot be done by the ministry alone, but it requires concerted efforts from various stakeholders. When it comes to vaccines, again, they committed to say we need to at least have at least one vaccine in the next 5 years. And this runs from 2023 to about 2027. When it comes now to finances, because TB cannot be fought or cannot be eliminated without proper financing, you remember in the past 2018-2022, the heads of states had committed to say they were going to raise about $15 billion towards TB, of which 13 billion was towards case finding and diagnostics, and the other 2 billion was supposed to go to actually research. But in this commitment, they've committed to increase that to about 22 billion, of which about 17 has to go into patient care and also diagnostics. And the remaining 5 billion annually, this figure we're talking about is annual figure of 5 billion should go to research. So based on that commitment, so now figures that accompanied it is that we are now being mandated to find about 45 million people who should be linked into TB care globally, and of which 4.5 have to be children. This is about 10% of that. And when it comes to MDR, they have said we need to find about 1.5 million. This figure hasn't changed from the previous 2018 to 2022. And then when it comes to TPT, again, we have moved from the previous 30 million to about 45 million. These were commitments, of which 30 million has to be household contacts, and the other 15 million has to be the people living with HIV. Now, when it comes to country now level formulation of those targets that we've talked about, the 45 million, 4.5 million for pediatrics. So our country targets is now what has been shared in this table. I know most of you might want it, but I can still share it with you. Just you'll see that for the trend, for example, for notification, it correlates what we had projected also within our NSP to say we'll see an increase in the number of cases that we're identifying, with the peak being 2024, and then we start declining. You remember that peak of going towards the incidence, that once we find everyone, it will be difficult to find cases. So it's actually epidemiologically right to say we will need to struggle actually to find new cases as we go forward. So we've been given those targets from the UN high level. It's not programmatic, but the UN high level targets. So now, as a program for the year 2024, these are our new targets that we are working with for the year 2024. As you may see, we have dropped a bit from the previous year where we had about 63,000 as a projection for 2023, and we only identify about 53. So we reduced this figure on account that we want to add more quality to the work that we are doing for both bacteriologically confirmed and also clinical diagnosed cases, but also sustaining a good performance that we'll all be proud of to say, yes, these are real cases. So that is the distribution per province. And we've gone a step further to say we need to disaggregate this information by giving people the targets. So when you look at the bacteriologically confirmed, that is 65% of the notification for a district or for the program that we need to see at the end of the year. So those figures represent a 65% reduction. A 65% of the total notification that we are supposed to give, of which the pediatric we have targeted to move at 12% from the current 11%, and those are the figures. But of importance, we've emphasized on the role of community contribution to our notification. So we've also given a target there of about 10% to be coming from the community, which translates to about 6,000 cases distributed like that. So from those notifications that we have, contributions that are happening from the community aspect, those of us who are NGOs who are helping us with the community, we should make sure that we use the right registers, use the right reporting so that we capture that information. And finally, we have the targets for MDR, which we've still maintained the high there. Although the performance for this year, we sit at, as of 2023, we sit at 388, which is a bit higher than the previous year, which is 2022 again, but we still fall short of where we want to be. Can move forward. Okay, for now, over to you, Dr. Mutumwa. I hope people had polled for the previous poll that we had posed.
No, we had challenges with launching the poll, but I think things will now be fixed. So we'll move on to our next poll question. And our third poll question is regarding childhood TB. So the question is, according to the World Health Organization recommendation, the age range for the shorter treatment regimen in children and adolescents with non-severe TB is? So according to the World Health Organization recommendation, the age range for a shorter treatment regimen in children and adolescents with non-severe TB is A, 3 years to 16 years, B, 3 months to 16 years, C, 6 months to 14 years, and D, 3 years to 14 years. So we want to hear from you, Tim. What do you think the age range is for children who qualify to be on the shorter treatment regimen according to the World Health Organization? Okay, we can see the polls are coming in very fast. Okay. Charity Chirwa, we want to know what is your opinion on the WHO recommendation for the shorter treatment regimen for adolescents and children with non-severe TB. Okay, we'll be ending our poll shortly. Okay, our poll has ended. Okay, we can just go back to the previous poll. Okay.
Dr. Muyangana, there are 2 parts in this poll, so we're just loading the second part now.
Okay. Are we able to go back to the previous poll because the questions are 2 different questions? We view the results from the previous one?
Yes, we are able to view the results. So we'll show the results together.
Okay. So we'll move on to the next poll. The following are the eligibility criteria for initiating someone on the drug-resistant TB, someone with drug-resistant TB on the BPAL or BPAL regimen, except. So the following are the eligibility criteria for initiating someone with drug-resistant TB on the BPAL or BPAL regimen, except A, or MDR or RR-TB, B, pre-XDR TB, C, all forms of TB, PTB, and EPTB, D, children less than 12 years old. So which of the following are the eligibility criteria for initiating someone on DRTB on a BPAL or BPAL regimen except A, OMDR RRTB, B, pre-XDR-TB, C, all forms of TB, that is PTB and EPTB, and D, children less than 12 years old. Okay, we can end the poll now. Okay. Thank you. We can, yes, thank you, Kote. So, Dr. Mubanga, the majority of our team feel that children who are between the ages of 6 months to 14 years are the ones the WHO is recommending for the shorter treatment regimen for non-severe TB, whereas we have 25% of the participants thinking it's 3 months to 16 years, and we have 27% thinking it's 3 years to 14 years, and we have 12% thinking it's 3 years to 16 years. Okay, so maybe I just review the results for the next poll so that you can speak to both of them at the same time. Okay, we can, you can project, thank you. So we have 34% of the network thinking that all of the following are in eligibility criteria except C, which is all forms of TB. And we have 31% thinking the answer is A. And we have 26% thinking the answer is D. And only about 8% thinking the answer is B. Over to you, Doc.
Thank you so much, Doc. And I really appreciate the feedback from the network, and it actually speaks to the level of commitment that we need to put in for us to actually get the best at the end of this. And starting with the eligibility criteria there, it's even almost similar to this. So for me, what I'm seeing here is that the program and you, our dear partners, we have a lot of work for us to actually make sure that we transmit the right information to our people so that they understand. So the right answer, actually, what WHO has recommended for the initiation of the shorter treatment regimen for children, the lowest minimum cut is 3 months, and the upper limit is 16 years. But I'll explain in the next presentation where programmatically we've moved from 16 years to 14 years. But otherwise, the right answer there is the child as early as 3 months is eligible for the shorter treatment regimen. And there's nothing much special about it except that we really just need to know what is the definition of non-severe TB. And in the next echo session, we'll try and dive into the criteria and the nitty-gritties of this shorter treatment regimen. For now, I'll just give the key highlights. As for the MDR-TB use of BPAL regimen, this is a regimen, again, that was just adopted in the year 2023 by WHO fully to be utilized in programmatic setting. And again, we'll have a lot of discussion and also a lot of engagement and trainings, both on-site and also using this platform to bring the right information. But the current guidelines it's not for children less than 12 years. So some people would just say, no, it's not for children. Simple. 12 years going down, don't consider them. So we can move now to just a summary of the presentation on these two items. So I'll just try and give you colleagues a bit of key highlights on where we are and where we'll go. But the scientific part, we will need a bit of time where we'll present a detailed presentation on each of these treatment regimens. So when we look at the background about the shorter treatment regimen, is that it's one of the regimens that we've included in our current TB guidelines, 2022 treatment guidelines. And it's a 4 months regimen where we are using the same drugs that we are using for the 6 months regimen, except that the duration has been shortened. And in Zambia, as I mentioned, 3 months to 16 years. But for the programmatic setting, we've revised this to 3 months to 14 years. This is to cover for the periods in which we are reporting as a program, you know that the data we capture only goes from 0 to 5, then from 6 to about 14 years. So it becomes difficult if we are doing this in a program setting to come and report for the age 15 and 16 years because they are falling in the adult stage. So this has been done for programmatic setting and reporting as a country. And when we look at non-severe form, it is where it is recommended. And again, there will be a clear guidance, and that guidance has already been provided through the training materials that we've mentioned. And also in our treatment guidance, we try to put a bit there, but more information has been incorporated in some of the training materials that we are using for you, our provincial teams, and mentors that we have mentored already in the provinces, various provinces, have already been availed with these materials that we are using that clearly define what a non-severe form of TB is that qualifies for this shorter treatment regimen. So again, when we look at the same shorter treatment regimen, I would want to share where are we as a country, because you may be wondering something that has been in our guideline, I think, for the past 2-3 years. Where are we now as a country? So we remain very, very now objective and also optimistic to have this rolled out throughout the country. So you find that we have already started this rollout plan. We started with Lusaka and Copperbelt, where we targeted districts. And we also conducted train of trainers for all provinces, where now we can actually have a pool of specialists within the province that can cascade these trainings further down. So our plan is by end of Q1, at least 5 districts in each province should start initiating the shorter treatment regimen. We had started with Lusaka and Copperbelt to learn lessons from there, and I think we've learned much lessons. The first cohort actually completed their treatment in December as of last year. So we are now in a full gear to roll this out to other provinces. Then we are talking about 100% coverage with STR by end of the year 2024. So what we mean here is all the districts in the country, at least they should be able now to start initiating this shorter treatment regimen. As I mentioned, we just need to give you clear guidance on what is non-severe TB and what is severe. That is it, because the regimens that we are using are the same. So that is where the emphasis is. Of course, more information, as I mentioned, we'll be able to share with you in our next presentation. Then also it comes to reporting, we are using the Smart Care form, where we have also started this installation and expansion. Again, it will speak to some of the programmatic priorities in the TB program that is aimed to strengthen the reporting for these shorter treatment regimens that we have added, and also the routine data reporting. When it comes to DR BPALM regimen, where we have bedaquiline, pretonamide, and linezolid, and also in where we add moxifloxacin, we'll find that again, this, as I mentioned, was recommended by WHO, and the program had already was in the process of actually doing this as an operational research, where before the full recommendation came in, we had put in something to say we needed to start as a program. But before we could even begin, because the commodities delayed, we were told to say now it can be used in a programmatic setting. So we won't go back to the operation. We are going to start this process now. So you'll find that the eligibility, again, criteria for the clients, actually it's for all MDR patients, and our target is 80% of our MDR patients in this current year, 2024, should be on this regimen. And this also can be used in pre-XDR patients, where we drop off the moxifloxacin and concentrate just on the BPAL. And it can also be used for all forms, both pulmonary and extrapulmonary TB. The HIV positive individuals are eligible. And where we have this exposure to these drugs, bedaquiline, linezolid, pretonamide, or delanamide, less than 1 month, again, we can always use it, because you can see that the only addition to what we already have is pretonamide. And bedaquiline, linezolid, and moxifloxacin, we are already using this in the oral regimen that we have. So now that we have brought in the pretonamide and these other new molecules as part of the treatment, we are always emphasizing on the need to actually have active surveillance for drug reaction that may occur. So where are we as a country as well on this one? So as I mentioned, commodities, we've managed to secure them and already we have them in the country. And we've already drafted the implementation plan. But apart from this, we've worked with the various stakeholders within the TB space, and we want to learn from our colleagues who are already implementing the BPAL. So we've requested for a tier which our partners are willing to support, which will be done as part of the training package that will be offered to colleagues from the provinces and the districts as part of the training for BPAL. So this is all expected actually to happen in Q1. We are very much advanced in terms of the preparation for this. And we plan by end of February or beginning of March, the team will be on the ground to start the trainings and also the rollout of this BPAL regimen. For TPT, as you may be aware, we have this shorter treatment regimen, 3HP, 3HR, that has been in circulation. And we also last year received the 1HP as part of the dosing. Now, I've highlighted the 1HP because most of you colleagues are not aware that actually it is within your facilities, it's within your districts that you can make use of it. So this 1HP regimen is highly recommended in an age range of above 13 years. And it can be used in all these groups, especially in the HIV negative population. However, it can also be used in the HIV population with, of course, consultation from our clinicians, especially that those of our clients who are on dolutegravir, they might need a bit of adjustments on the dosing part, but it can be used in the HIV positive populations. So when now we move to the priority areas. Based on this presentation, I'll quickly just run you through the priority areas that we have. And some of them are actually stemming from what I've spoken to, the gaps that we've already identified. So when we look at the priority areas, we have about 4 to 5 priority areas. The first one is TB screening and diagnosis. If we can't find the cases, we can't do anything about TB and the program is dead. So we have prioritized intensive case finding and active case finding. So intensive case finding, this is where we are even looking at health facilities. How much is the index of suspicion amongst the people that we are coming to our facilities? That is our lowest hanging fruit. We need to look at the contact investigation that we've always sung about to say, this is an area where we can get a lot of positives, and each time we intensify on it, it gives us results. So again, most of our activities as we do the contact, as we do active case finding, they have to be linked to contact investigation. And this is where the community aspect need to be strengthened for all our partners and colleagues who are supporting us with community activities. We are still expanding on diagnostic networks, where we've introducing the TrueNut, which has the validation process has already completed. The findings, I think, have been shared on a few platforms, but we are yet to share with you as the entire nation. But the findings are actually good and are in favor of these two. So we plan to have these two once the machines are in the country. We will be able to deploy them, especially in places where we have limited access to power. Then we also have increased surveillance for MDR-TB, where we have increased also on the issue of XDR machines being distributed in the country. So you have our XDR machines being deployed and also the whole genome sequencing accompanying that surveillance so that we truly look for MDR in all the cases that we are suspecting to have TB. Then we need to optimize the current diagnostic tools via referral those without the diagnostic to use like expert. We need to have a way of optimizing the current tools that we have. The data that we have currently shows that we are using these tools suboptimally. Even places like Lusaka, where things are concentrated, we can only utilize about 50 to 60% of the capacity that we are supposed to get from there. So radiological coverage still remains our priority. Involvement of private sector. Initiatives of quality improvement is an agenda that we've even included in our Global Fund as a strategy that we need to employ for the TB program to get the best result of what is happening. Treatment and care, TB is not just a public health disease, but it has also a big component under the clinical. where we need to ensure the commodity supply is always maintained. And we build capacity for all our stakeholders who are involved in the fight against TB, starting with our volunteers, our health staff, where we need to manage our patients well. The CEC needs to be strengthened at all levels, provincial, national, district. We need to have these CECs strengthened. I've mentioned about introduction of these child-friendly and patient-friendly regimens that will improve adherence and patient treatment outcome at the end. We've also noted that nutrition support becomes a cardinal aspect of our patients that are receiving care. And at the moment, the MDR patients remains a priority. And we have actually adopted the provision of nutrition support for our MDR patients countrywide, because the number that we are dealing with is low. But we would want, I think, as the program expands through the implementation of the multi-sectoral accountability framework, other eligible TB patients should be able to be co-opted in programs like this for us to speak to the reduction in the catastrophic cost. TPT, same thing, commodity supply, rollout of these shorter treatment regimens still remains a priority. And also expansion of the coverage, especially amongst the HIV negative eligible groups. I think this is where we've lagged behind. And this year we want to concentrate on this, and we'll try and do a baseline assessment of how much people do we need to cover. And this is already, I think, taken care of by one of our partners who've come on board to help us with a baseline assessment so that we have a targeted approach to these populations. Then we need definitely to continue saturating our people living with HIV with TPT, those who are eligible. M&E, without it, we are bound to fail as a program. So we need to sustain initiatives that we've seen work, like the TB situation room. Smart care coverage, as I mentioned, becomes cardinal as we are looking for patient level data. Currently, the form in which we have is we have a lot of aggregate data that cannot inform us much about the happenings with the patient, but is only giving us a glimpse. So we would want this, it remains a priority, to be one of the things that should be implemented in this year, the coverage for smart care. Introduction of the TPT app, again, it speaks almost similar to smart care, but it's an app that will strengthen our community data collection. For example, contact investigations, it will give us that cascade of care that we are providing to our patients, whilst feeding into our main system of smart care and also DHIS too. Then, as I mentioned, the prevalence, TB prevalence survey still remains a big priority for the program, so that we can actually design interventions that will speak to us ending TB by 2030 based on the current burden of the disease. Under advocacy, communication, and social mobilization, we have seen, and we can all attest to say, the TB in the country still remains there are a lot of myths around it. So we intend to launch this SELSM launch in this same quarter, taking advantage maybe probably of this coming World TB Day, where we'll launch this document and it becomes part and parcel of our day-to-day operations. The introduction of the TB Echo platform for the community team, which we've already initiated with, of course, support from stakeholders, where we have started Eastern and Western. But this is another initiative that we would want by the end of the year to be cascaded to other provinces and districts, so that we empower our community soldiers. Increase TB awareness, launch and operationalize the multi-sectoral accountability framework that will take care of a number of things that we might have spoken about as a program, and also involving you as stakeholders. What is my summary? I've said a lot of things. TB, we should all know that it remains one of the top 10 causes of, I think, morbidity and mortality in our country. And the incidence continues reducing, but it is not up to the desired reduction that we want as a program. Then the mortality still remains high, though there has been that market reduction that we can boast about, but every life lost speaks millions to what we need to do. Every life lost is very precious for us. Then the percentage for catastrophic costs still remains high, and I need to mention here to say, a big chunk of this catastrophic costs actually came from non-medical related costs that our patients are facing. So we need to focus on interventions that will actually bring some of these services as close as possible to the community to cut down on certain things that they might be incurring as they move. Then TB shorter treatment regimens, I need to repeat this, are available in the country, both for the shorter treatment, for pediatrics, for the MDR, and for TPT. Let's make use of them, and more support definitely from the province, from the districts, and also from the national level is needed for our people on the ground at facility level. Thank you so much, Dr. Muyangana. This marks the end of my presentation. That's part of my references.
Okay, thank you so much, Dr. Mubanga. I can see that you did not miss your summary classes in high school because you have summarized your presentation so well, and we are doing so well on time. So as of now, I'll open it up for discussions with the team that has joined us. So please, if you have any questions, please do feel free to raise your hand and ask those questions. But also I would like our panel of experts to also just prepare something that they're going to add to this presentation and talk about some of the key areas that Dr. Mubanga highlighted in his presentation. So we can have Dr. Ziko speaking to the quality of care for TB patients. What should the people on the ground do or look out for this year when it comes to the quality of care for TB patients? And in line with this, he may also speak about TB treatment outcomes. Then I would like Dr. Zimba to speak about childhood TB. I know Dr. Mubanga touched on the shorter treatment regimen, but what are some of the things that going forward we would want the people on the ground to look out for and to do? Then we would like Winnie Mwanza to speak about the lab aspects. What are some of the things that the team should do and make sure that they implement on the ground so that we can report better this year? And Dr. Mputu, you may speak about DRTB, and we can have Dr. Chimzizi closing it off by speaking about the M&E aspects. So if there are any questions, please raise your hand and we'll be able to address them as the panel of experts prepare to contribute towards the discussion. Any questions? Okay, so we have a question in the chat coming from Mwyeza. So Mwyeza is saying 1 HP is available, but our facilities as highlighted in the presentation is available as highlighted in the presentation, but there is no implementation to drive uptake. Anything the program can do to see that the commodity is utilized. So Mwyeza would like to know what are some of the things that we are going to do as a program to make sure that 1 HP uptake is increased. Okay, so Chipego was saying, may you also explain the abbreviations so that we move together? Chipego, apologies for that. I think we'll do better next time to ensure that we explain those abbreviations. There's a question from Peter. What of these adults with minimal TB, especially those that are diagnosed using the mobile track, can they be qualified for the shorter treatment regimen? So Peter is asking, are we implementing the shorter treatment regimen for adults? Okay. Ruth Gondwe says the guidelines say 3 months to 14 years. No answer on the options. So Dr. Mubanga, maybe you'd also like to speak to that.
Okay. Thank you so much, Mwyeza, for that observation. And I think it's a timely observation where you've talked about having the commodity in the facility and then the uptake or the utilization of the commodity is not optimal. So one of the things that I think we did from the program side where when we had received the 1 HP, is that we embarked on the trainings throughout the country. So we started, as usual, we started with a trainer of trainers where we built capacity in the teams at national and also at provincial level. And then we followed that, I remember it very well, in the month of November and December last year, with facility or district level trainings where again we created some mentors at the district level so that they can be the people who can now manage the day-to-day implementation of the 1HP rollout. So it's a good feedback. And I think at this point, what we just need to do is, one, we need to keep first and foremost singing, because I've been to some facilities, as you rightly put it, where they don't even know that they have the commodity. So we have need a multi-sectoral kind of approach within the dimension of the Ministry of Health, where people from the pharmacy need to heighten on communication. People from the clinical side also need to heighten communication to say we have this commodity within our facilities, so that at least there is uniform information available. Then two, using the resources that we have. I know we are talking about, for example, contact investigation. And we are running campaigns that we are doing for contact investigation. This is an opportunity where we need our, for example, public health nurses, our HNP nurses, to see how we link now contact investigations to TPT. So this is, I think, one of the things that we are actually planning, first and foremost, to discuss with our coordinators, to link TPT to contact investigation and make it part of the routine deliverables that we are doing. Then a quick comment on the adults with minimal TB. Unfortunately, you know, this shorter treatment regimen, I'll allow maybe Dr. Zimba to speak to that, and the study in which it was, the trial in which it was done did not cater for that. So this shorter treatment regimen that we are talking about for pediatrics only was done in that category. But I'll allow Dr. Zimba, as he comes to talk about shorter treatment regimen, add more to that. But it is based on the research that was done and the age group that was involved in it. However, there is also a shorter treatment regimen for adults that WHO has recommended, where we are adding a fluoroquinolone. Now, as you may be aware, a fluoroquinolone is one of the drugs that we are using in the MDR. And this, as a program, we need to weigh what are the benefits of using this at the moment. If the patient becomes resistant, you can see even the BPAM regimen already has a quinolone in it. So that is still under discussion, and we want to give the best to our patients other than exacerbating the problem. But I'll ask also Dr. Mputu, as he speaks to the MDR, to come and just give one or two comments. Then speaking to the answers, I know 3 to 14 months is what has been put in the recommendations. As I mentioned, this 3 to 14 years is programmatic. As a country, when WHO recommends, we adopt and then contextualize it to our own setting. So WHO ranges from 0 to 16 years. But as a program here in Zambia, what we had put in place is the issue of monitoring and reporting. If we include the 15 and 16 years, we might not have anywhere where we can catch them within our routine program reporting. So we had to opt to go up to 14 years because that's the age range that we are reporting on. And again, I'll ask Dr. Kevin, as you come and give a summary, to come and just speak to that. Over and thanks.
Okay, thank you so much. I can see 3 hands, Paul Mwale, Mavuto Simwinga, and Mungomba. So we will start with Paul Mwale. Paul Mwale, you can unmute and ask your question or give your contribution. And when you are done, we can have Mavuto, who will be followed by Mungomba. In that order, please. Paul Mwale, are you able to get us? Okay, if Paul Mwale is not available, Mavuto, you can go ahead.
So sorry, Chair. I was not allowed to unmute myself, but I think I've been allowed now. Okay. Thank you so much. Good presentation, Dr. Mubanga. So I think for me, I'm asking this question on behalf of most of the private sectors that have actually, the private sector have actually visited right on the Copper Belt province concerning TPT, high risk, HIV negative populations, You know, Copper Belt and pneumoconiosis, they are very good friends. Kitwe, we visited some of these facilities, you know, who are busy asking about, you know, TPT in these clients who are not negative and they have pneumoconiosis. Has this been included, you know, in the guidelines? I think that's my straightforward question. Thank you.
So much, Paul. Mavuto, you may go ahead.
Hello, good afternoon, network.
Yes.
Am I audible?
Yes, please.
Okay. Yes, thank you. Thank you very much. That was a very good presentation, Dr. Manga, very informative. So for me, my question is, I wanted to find out, at one point you mentioned that there is support given to MDR patients who are having drug resistance TB. So I wanted to find out how that fund can be accessed. And then the other one is, if we look at our end strategy TB, which is the catastrophe one, there is a support given to MDR patients in terms of maybe access to TB drugs, but is there any funds to non-MDR patients to access MDR funds? Because we know that sometimes even a normal TB patient can have challenges to access TB care, more especially in rural areas, looking at some distances from healthy facilities. Thank you.
Thank you, Mabuto. Mungomba, you can go ahead and ask your question or give your contribution so that Dr. Manga can take them all at once.
Okay, thank you very much, Dr. Mutumwa and Dr. Angel. This is a very wonderful presentation, quite excellent. My contribution is on the TB HIV co-infection. When you were presenting on the epidemiological data, we saw that yes, even though we are having now an improvement in the HIV TB program, but still, we still have quite some numbers of HIV TB co-infection. In some areas, in a given reporting period, you may even see HIV clients being reported on the higher side than the non-HIV clients. So while we appreciate the effect of INH, the TPT in general, in regard of HIV TB co-infection, is there any study which has been done of late to really critically understand why we are having HIV clients being co-infected, even though measures have shown quite progress on the TB PrEP part? Thank you.
Thank you so much for those questions. Dr. Manga, you may take the three.
Okay, thank you so much, Dr. Chimzizi. Be ready for the TB HIV co-infection at the end. The first one, I think, was coming from our colleagues saying in the private sector, we still have quite a number of pneumoconiosis patients being seen there, but have we included this group as part of the people that should be considered for TPT? So colleagues, I think, to make clarity here about just a bit of the background of the TPT program in Zambia. So when you look at how we started this program, that was 2017, we looked at the commodity supply and availability by then. So when we did the analysis, I think one of the things that the program settled for was, yes, we have these high-risk populations that can benefit from TPT, but let's start with the most vulnerable according to the assessments that was done at that time. So I remember at one point I was part of the train of trainers for even a pilot where we are piloting it in other HIV negative eligible populations. That was around 2019, 2020. So what was settled was HIV people becomes a priority. And that's how the commodities that was available, we tailored our intervention towards the HIV positive population. But what we've seen over the years is that when I presented, I think we have almost reached saturation. Over 90% of our eligible HIV population have been covered with TPT. And we have seen now a shift where now we are having the incidence of TB being more in the HIV negative population. So at this point in time, we've seen that we have quite enough commodities to cover now, even for these other risk population. So in short, sir, the pneumoconiosis patients, we have actually clearly outlined to say they are eligible for TPT once we rule out active TB, and they should be considered for TPT just like another eligible candidate. Now, looking at the private sector, I think this is an area that I spoke to say we need to strengthen the private sector participation in the fight against TB. As we've seen also, we have a lot of this NEMA being implemented in the private, and most of the patients will end up in the private sector. So it's inevitable as a program that we bring you on board, we train you. If it means capacitating you, we need to capacitate you so that we can be able to actually initiate all the TB or offer all the TB services that are there. So yes, in short, pneumoconiosis should benefit from TPT and should be accessed from the provincial once we are trained and we have right staff to give this life-saving treatment. MDR support, is it available? So the answer is, initially the MDR support was actually being covered under one of the projects called the World Bank supported project, service project, and it ran 2018, 2019, somewhere there, but with the reduction in funding, I think we stopped having that support. However, we had an opportunity in the previous year where we were working on the Global Fund grant, and one of the priorities was we still wanted the MDR patients to be supported, not because they are the only eligible candidates, there are other vulnerable people, but we looked at the masses with the little resources that was available. Whom could we start with? So this is why we have actually had inputted MDR people to benefit from that, but this is just the beginning. And colleagues will be able to access this funding. Communication is coming to the provinces, communication is coming to the districts. The current dispersing of funds will also include the MDR portion for the support. And on top of the nutrition support, there will also be attached some transport refund for our MDR patients. So again, as a ministry, learning from what we had done in the past, I think it's something that we are working on the modality. What is the best modality for our patient to benefit from it, other than having the lacunas that we had noted in the previous implementation. So our desire is, as we implement now the multi-sectoral accountability framework, where we need to bring other ministries on board, like the community development, which looks at vulnerable, we should be able to actually have some of other clients supported with such similar support from the other sources of funding. But the current funding that we have under Global Fund, we only budgeted for the few MDR patients that we have projected as the number for this next 3 years. But we need to have a sustainable form of sustaining this initiative. And that is where I think we are as a program. Then TB HIV co-infection, Dr. Chimzizi, you make a comment on that, please.
Yeah, thank you so much, Dr. Mwanga. It looks like you could have even handled that because you have done that excellent work. No, so I think just to agree with the colleague that the TB HIV co-infection is still on the higher side, but you also appreciate that this has actually reduced over time, looking at 60% in 2018. By 2022, the TB HIV co-infection reached 32%, as Dr. Mwanga already stated. However, I think we are not relenting in terms of because of this has reduced. We believe, I think we are still missing quite a lot of TB among people living with HIV, particularly that they are always, most of the time, they are post-bacillary. So I think we'll be interested to see the work that our HIV program colleagues and CDC are doing, because they're doing targeted universal testing, most especially in the advanced HIV. As a program, we'll keep in touch to make sure that we can get those results and see what we can do. I'm thinking that the issue of bringing in chest X-ray as part of the screening among these TB HIV co-infected patients would actually find a little bit more cases than what we're doing. Thank you so much, Dr. Mwanza.
Thank you so much, Dr. Rhehab. And it's good to hear. But one of the things that, just to add to what Dr. Chimzizi has mentioned, is that as a program, what we've noted is we have quite a number of research bodies that are conducting research, sometimes even without the knowledge of the program. And currently we are at a stage where we want to bring a team of researchers as close as possible, especially those who are dealing with some TB-related, also HIV-related, TB, HIV-related research, so that we start co-opting some of the findings and translate them into programmatic setting. So we have formed the research committee out of the technical working group that will specifically be looking out for these publications that different partners and stakeholders might be doing anywhere. So again, it's an appeal to all of us research bodies that might have joined here to take interest in this and be able to inform the program so that some of these good research findings, we can actually translate them into program setting. Of course, as a program, we continue doing some of the operational research, but sometimes we are limited in terms of capacity and time to do a very comprehensive work. So it's an appeal, I think, to the network to give us that support. Thank you.
Thank you so much, Dr. Mubanga. There's a comment in the chat, and this is from Chipego Munza, who's made an observation that she feels that, or he or she feels that TB programs seem not to be well funded at facility level compared to other programs such as the HIV program. And this has made it difficult to implement things such as contact tracing, which I think for this particular facility is being conducted on a quarterly basis. So I think as the experts are giving their comments, maybe you can prepare to speak to this at the end of the session. So we will get comments from our experts, starting with Dr. Ziko, who's going to talk about the quality of care for TB patients this year and what we expect to see in the treatment outcomes. Dr. Ziko, over to you.
Thank you, Dr. Muyangana, for this opportunity. So when it comes to the quality of care of our TB patients, we start with the patient at the point of diagnosis, where we need to ensure that we have full clinical assessments where we do a comprehensive history, comprehensive examination with the vitals taken and action taken against those vitals, because a number of times you would have a patient who just comes with a positive diagnosis and we forget right there. But then we forget that these patients could have other issues that may be going on with a low BP that may need immediate attention. We'll also need to do safety labs where these labs are available. If they are not available, even using other opportunities such as NEMA, we can link some of our patients who are registered to NEMA to obtain some of the safety labs that are very important for their safety. We know that some of these drugs have side effects, and having a baseline lab is important in order to ensure that the patient is well covered. Even when we collect the weights on a monthly basis, we need to also ensure that we follow the weight trends. If, for instance, someone has been on TB treatment for 1 month, 2 months, and you're not seeing any weight change, that should be a red flag, and certain measures need to be taken care of. Other than that, we need to be able to identify different comorbidities. Remember, the TB patient, just like any other patient, HIV or so on, can come with other problems as well. They can come with hypertension. Majority of the patients that we have who die do not die of TB. And that is because sometimes we neglect to look out for the other comorbidities, which may take the patient's life. So we need to look out for the other comorbidities, hypertension, diabetes, HIV and TB, there's some kind of good collaboration, but still needs to be strengthened. We heard about the drug-to-drug interactions that may take place. All those need to be taken care of in order to ensure that both the TB and any other comorbidity that may be present are adequately handled. And so in as much as we identify the comorbidities, we also need to ensure that we have adequate management skills of those other comorbidities, because what we want is to encourage integration of services where a TB patient can be seen in a diabetic clinic and be able to receive optimum care right there. If they go to a primary healthcare level facility, the staff at the facility should be able to handle. But if they are not able to handle, probably based on inadequate skill set, there should be that referral mechanism where a patient can still be able to receive care at the next level of care. Other than that, we need to be also able to link our patients to treatment. When our patients receive treatment at our facilities, sometimes they may not reside within the catchment area of that facility. So using some innovations such as the contact directory, I hope a number of us are aware of this innovation. This is an online tool which has facility contact details across the country, such that if you are linking a patient to another facility outside your district, or within your district, outside the province, and wherever the patient may be going, you should be able to link that patient directly to the facility where the patient is going to. So that coordination is very important. I've seen a comment in the chat where someone is talking about contact tracing among the TB patients. That's another issue that we need to ensure, that even as we link our patients to other facilities, both for follow-up and contact tracing, that will help with the overall management of this patient. Then surrounding all this is the issue of data management. So you can do a very good job with diagnosing a patient, treating the patient, and ensuring that the patient is successfully cured or treatment completed. If you do not document, your efforts will not be appreciated anywhere. So paramount to all this is the issue of ensuring that our documentation, our data management, right from diagnosis, whichever service delivery area we are talking about, the presumptive registers, contact tracing registers, the lab registers, treatment registers, contact tracing registers, all these registers should be optimally documented, well documented, using the appropriate standard that has been prescribed in the registers. And then other than that, we need to appreciate the data. So we shouldn't just document and wait to report. We should also analyze our data at facility level, at district level, provincial level, so that we can understand the gaps and put in corrective measures in order to help the TB program as a country, contributing to the global picture, win the fight against TB. I'll end here, Dr. Muyangana.
Thank you so much for that comprehensive submission, Dr. Ziko. We'll move on to Dr. Zimba. You may speak about childhood TB. And as you're speaking about childhood TB, please talk about TPT for children, especially infants. I think there's a question in the chat regarding that. In under a minute, please.
Thank you, Dr. Muyangana, and thank you, Dr. Mubanga. Very good presentation to the NTP, and I think to everybody else. I think very ambitious targets. Let's keep them. 12% notifications for childhood TB is, I think, very achievable. What we need to think through as a network is how to use the treatment algorithms for childhood TB, how to make a diagnosis. Let's use those treatment algorithms. We have one that's for the children living with HIV, and one that's for children not living with HIV. If we use those algorithms, we'll be able to make a good number of diagnoses of TB among these children and hit the 12% target that we've given ourselves. I know many people are afraid, stop making diagnoses of TB because of the strictness that we applied in the use of urine lamp. But if we use the treatment algorithms, we'll be able to make a diagnosis of TB. coming to the shorter treatment regimen for children, like was presented by Dr. Manga. Yes, we said 3 months to 14 years for programmatic sake. Children have low dose bacilli, so they don't have a lot of TB germs in them, and that's how come the 4 months treatment was easier to implement in children than in adults. And studies that have been done so far are showing that for children who have minimal infection or low bacilli, the treatment outcomes are the same compared to those that have received 6 months. Hence, us only giving the children and not giving the adults. So we need to have enough evidence in that area that speaks to that. Then when we come to case finding, one area that case finding is there for children is contact tracing. That works both for TB preventive therapy and finding more TB children with TB. We've noted as we go around doing site visits and technical support that we have very few children that are elicited as contacts among TB patients. So we'd like to urge you members, and this is one of the priority areas that we have as a TB program. We want to find more children that need to receive TB prophylaxis through TB preventive therapy, and more children that need to be diagnosed with TB for us to get the 12%. So let's find more children who are as contacts. I think every household in Zambia has a child that lives with them. So we need to be quite stringent about that. And I think I've spoken about TPT. Just to comment, I think Dr. Mungomba, your question is that of just an experienced mentor. I know we've been seeing this decline on HIV TB. We are at 34% of our TB incidents, but when we actually look at the actual numbers, they've more like stagnated. We've not seen an increase in the TB patients. We are around 17,000 TB patients that are HIV co-infected with TB over the last 3 years that are there. So we've stagnated in terms of the number, but the overall burden is not increasing in the PLHIV. So we still have patients that live with HIV that develop TB, and it's estimated we are missing a good number of them. And you will see a lot of interventions coming forward in the HIV program that are looking at finding more PLHIVs to be diagnosed with TB. With that said, I think, thank you.
Thank you so much, Dr. Zimba. Dr. Mputu, you may speak about DRTB. We are running out of time, so we will only give you a minute to speak about DRTB, and then we can close it up with Dr. Chimzizi to speak about the M&D aspect.
Thanks, Doc. Good afternoon, network. Unfortunately, they've given DRTB less than a minute, and yet DRTB is the thing that is threatening the whole TB program anyway. So just a quick comment with the DRTB. Like you saw that the program has been having challenges in identifying cases. So one of the biggest gaps we have with DRTB is that we are failing to meet our annual target. Some of the reasons are that we are missing these cases in obvious situations. For example, we are seeing a number of patients who need to be tested for DRTB, like via molecular diagnostics or via lab, the main culture labs, but these patients are not are being tested as required. This is data that I've also think presented on this forum before. So we need to start being hyper alert in identifying potential patients with DRTB, so that we ensure that everyone is tested for either via molecular testing or via the lab culture testing. Regarding treatment initiations, we've done very well. So most patients are connected to treatment. However, the treatment of choice still remains the longer treatment regimen, although the world is moving away from the longer treatment regimen towards the shorter treatment regimen. So in the coming few weeks, we are going to again interact, where we are going to guide how people will start using the new 6-month treatment regimen, hoping that most of our patients will be put on this treatment regimen. And then related to treatment regimen and case finding is the treatment outcome for DRTB patient. We are still seeing an unacceptable number of patients either dying or being lost to follow up, and this is not this is something that we need to start looking out for in our facilities, why we're having a lot of patients lost to follow-up, or why we're having most of our patients dying. So we do not want to see anyone dying from TB, whether it's DRTB or susceptible TB. Some of these mortalities, if we pay attention towards, we can actually prevent them if we pay attention a lot. So the main focus for this year will probably be to look at these 3 areas of case finding, ensuring that we target, we test everyone who needs to be tested, and we find more cases, and then we have to start initiating treatment on the shortest possible regimen, and then we want to minimize adverse outcome that includes loss to follow-up and the mortalities. So because I have no time, I'm going to request soon that I'll meet the network again. I'll make a comprehensive, detailed presentation to the network over the things that I've mentioned. Over, Doc.
Thank you so much, Dr. Mputu. I know you had a wealth of things to say, but I think that those are the cardinal things, and we'll have other echo sessions, and the team, or rather the network, should look forward to those as you expand more on the DRTB. Dr. Chimzizi, just to sum it up for the M&E as we prepare to close the meeting.
Thank you so much. I'll be brief. Just to state that the program has made frantic effort in terms of moving into electronic case base, particularly using YATU, which is for DRTB, but also the coverage in terms of entry into the DHIS2 has increased, but also that platform has also been seen innovation. However, we still have major issues related to drug-sensitive TB. We are still hugely depending on the paper base, but the program manager recently met the developer of Smart Care to make sure the aim is to make sure that we move quickly in terms of increasing coverage and utilization of Smart Care, because we are not enjoying our data because it's still not case based. So most of the case, our data is aggregate. But also we are pushing that most of our gene experts should be connected to gene expert connected platform, so that we can get the results of the test immediately through DISA. So we are still working with our colleagues from the laboratory diagnostic services. So essentially, that's what we are going in terms of trying to make sure that we move away from paper-based to completely electronic case-based. With the interest of time, I would state that I think very important topics covered today. We do hope our colleagues, I think, have gained quite a lot. I think I should thank Dr. Mwanza for, I think is one of the best presenters, no stammering. So thank you so much, Dr. Muyangana.
Thank you so much to the experts. I wish we could have more time to talk about TB, and also just to share a bit more of some of the work that is being done on the ground, or what the network should anticipate. But because of time, we have to end here. But before we leave, Dr. Mubanga, you summarized everything so well, and we've had marvelous contributions from the network and also our panel of experts. So what are your final words? How would you end this presentation?
Thank you, Dr. Muyangana. And once again, I just want to thank the team, first and foremost, the ECHO team, for according the TB program an opportunity to present on such a platform. And I know in the past we've really struggled to have an opportunity like this, but this is a very excellent job. And to thank colleagues from the provinces and the districts, and just to continue also reminding our partners, stakeholders, that there is a lot of work in the TB space, and someone rightly put it to say, we seem to have little funding reaching the facilities, and even the little resources that we are getting as a program, we are trying by all means to devolve it to the lowest level where it can be utilized to get the best out of the lead that we have on the plate. So it's a call on each one of us as we go out there. Please, let's be ambassadors of the TB program, and let's continue on the trajectory of ending TB by 2030. Over and thanks.
All right, thank you so much. Thank you so much, Network, for joining this afternoon. It's been a good meeting. We've discussed very important things, and we look forward to the implementation in the year 2024. We also look forward to seeing you in the next ECHO session, which is next Monday. Thank you, and over.
Thank you.
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 Thank you from CTC here.
Thank you.